Hello, my name is Cameron Sabet, and welcome to Cutting to the Case. Today we're joined by Dr. Collin M. Stultz, Director of the Harvard MIT Program in Health Sciences and Technology, Nina T. and Robert H. Rubin Professor at MIT, Associate Director for MIT's Institute for Medical Engineering and Science, Professor of Electrical Engineering and Computer Science, Professor of Health Sciences and Technology, and practicing cardiologist at Massachusetts General Hospital. After earning degrees in mathematics and philosophy from Harvard College, Dr. Stultz completed both his MD and PhD in biophysics at Harvard University, where he trained under Nobel Prize-winning chemist Martin Karplus. Today, he leads one of the world's premier physician scientist training programs while directing research at the intersection of artificial intelligence, computational biology, cardiovascular medicine, protein biophysics, and personalized medicine. His work has advanced explainable machine learning for healthcare, computational modeling of disease, and AI-driven approaches to cardiovascular risk prediction. He's an elected fellow of the American Institute for Medical and Biological Engineering and a recipient of the National Science Foundation Career Award and the Burroughs Wellcome Fund Career Award. Dr. Stultz, welcome to Cutting to the Case.
Thank you. Thank you for having me, Cameron.
Thank you. So, you've had a remarkable career that's spanned mathematics, philosophy, medicine, biophysics. You could have really chosen any of those paths. Looking back, was there one thread connecting all of those interests?
I wish I could say that there was a cogent um, way that I thought about my career, but it didn't happen that way. I actually was driven by what I was most interested in. So in college, mathematics is something that I was interested in from early on, and then philosophy caught my eye, and it was towards the end of college and thinking about where I wanted my career to go. It really drew on my value system in terms of things that I thought would benefit the world and leave a tangible benefit to others after I died.
Hmm.
And while math is a wonderful thing, pure math in my view is more like art than it is anything else. And so that led me to return to medicine, and something that my parents and others had encouraged me to do. So it was a very circuitous route, but certainly guided by my interests, underlying value system, and using those two things as a guide, I ended up where I am now.
Wow. Wow. And that speaks to a lot of the modern uh, careers that are emerging that are so intersectional and across so many different fields. And there's no there's no need for a through line anymore or any specific thing. You can just chase your interests, and that's one of the beautiful things about modern careers. Um,
Sorry to interrupt, but one of the things
yeah.
I tell students all the time is that the key in your career is finding out what you love. I mean, I think lots of students think about, well, it's college, should I go to medical school? Or in medical school, should I go, what kind of physician I should be, or should I go to grad school? But if you can, at your core, identify the things that make you want to get up in the morning, the things that excite you, right? And you use those things to sort of guide your decision making. It sounds very abstract, but I think that there's some truth there. I think the decisions become easier to make.
Yeah. Yeah. And as you start to think about careers, you think about mentorship as well. You trained under Nobel laureate Martin Karplus, and that's remarkable. What's something that he taught you that never appears in a textbook?
Yeah, no, it's a good thing. So Martin, who recently passed away, was one
Sorry.
of the most talented scholars that I've ever known. And I think the thing about him that really stood out to me was how rigorous he was, and how detailed, how much attention he paid to detail. And those are things I try to carry on in my professional career. One of the two great things that he taught me. I think also he was a person of many different interests. So being, one of the world's best biophysicist and physical chemist, he was a wonderful cook. I think he was a three-star French chef. and
Wow.
he was a wonderful photographer. So although so much of his life was devoted to scientific investigation, he was a he was somewhat of a Renaissance man, and that although one could be very dedicated in their career, that you become having other interests in many ways can benefit your scientific interests and scientific pursuits as well.
Hmm. And in the path to becoming a physician scientist, a lot of students struggle between choosing between medicine, engineering, research. Was there ever a point where you thought I have to pick one, or did you always believe they could coexist?
Yeah, no, it's a good question. I think as a broader principle, there's sort of I like to say there's a physician scientist and there are scientist physicians. So one word has to be the noun and one word has to be the adjective. So you first have to decide what's the noun, right? Are you a scientist, and a physician sort of describes the type of science and such that you do? Are you primarily a physician, and scientific endeavors complement that? And once you make that decision, then I think the rest of it becomes a little bit easier. So I am a physician scientist. Most of my professional life is in scientific investigation, um, and leading a very talented research group. And then so that and the physician part, seeing patients, I do enjoy seeing patients, but it's those interactions that keep me grounded in terms of the real unmet needs that at the end of the day benefit those who are ill. And so I think once you kind of separate where most of your life is, where your focus is on the science or the patient care, then you can have a union between the two that's
Mm,
productive. There's no one size fits all.
sure.
Um, and earlier in I spent more time, it was sort of more divided between the clinical things that I do and the research enterprise, whereas now it's more sort of on the research enterprise and along
Mhm.
with some of the administrative things that I do that you mentioned.
Hmm. And how do you advise students who are trying to pick a lane?
Yeah, no, that's tough. That's tough. And I
Mm,
think this device, this not device, this advice has to be individualized. And the more that I know a student, an aspiring physician or a physician scientist or scientist, the better the advice that I can give. Because at the core, I think, returning to a theme that I mentioned previously, you really have to understand, one has to understand oneself as much as that's possible,
mhm,
right? In terms of what sorts of questions excite me, what sorts of activities. And I think for students, the first part of that is data gathering. So to know exactly the sorts of things in a career path that will best benefit you in the setting of uncertainty, data can help.
mm,
So what research experiences have you been engaged in? And the variety of those experiences, what you like, what you don't like. What sorts of clinical experiences have you engaged in, whether it be shadowing or otherwise? And so you could get a sense of where in the spectrum you want to lie, you want to be. I've always felt that an undergraduate experience should be very broad. You see lots of different things, and you can see all of the potential pathways, and then you can choose. So the first step is what data have you gathered to bring to bear in this decision? And then you can use those experiences to kind of tease out what kind of tailored career path is going to be best for you.
yeah,
I don't know if that makes sense.
it does. It does, and it's career lessons that translate not just to the MD PhDs, but to everyone really. Um, an MD is a remarkably versatile
Absolutely.
degree. So in becoming a physician scientist, now kind of moving forward from that step of deciding what scientific problem has kept you awake at night the longest.
Yeah, it's a great question. There are so many, it's interesting because of the questions that that I think torment me the most come from the precise patient experiences that I've had. So I can attach the problems with a patient who I've seen that either had a bad outcome or an outcome that is suboptimal in my view. And a lot of that now is around heart failure.
Hmm.
So heart failure is a more and more prevalent disorder, and our treatment and classification of patients with heart failure is really, really inadequate, preventing people from coming back to the hospital, reducing mortality. The morbidity from heart failure is quite significant, and our treatments are really um, not very sophisticated. So patients with heart failure go home, and oftentimes we tell them to use a very sophisticated device at home called a scale. Yeah. So they weigh themselves. Yeah. And they report their weights daily. And we use that in decision making, right? Just to give you a sense of where
Yeah,
where 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 where, where things are. So
sure.
there's a lot there. I want to touch on one thing that you've said that
Hmm.
actually um because it triggered a thought in my mind about an MD being a versatile degree.
Hmm.
And that is without question. I think it's one of the most versatile degrees that one can get. It seems like a non sequitur, but I just want to make sure that I get this point out of my
Yeah, yeah.
old brain before it dissipates. The so pa Students today often wonder about research and what one needs to do to have a productive research career and so forth. But MD PhD today, I'm not so sure that is the instances in which you really need a PhD is a lot less than what it was when I was in my training. There are ample examples of people with MDs who do very sophisticated and noteworthy um, um, scholarship, right? And who are great scientists. So I just want to reiterate that statement because I think a lot of what I've articulated could be interpreted that it's specific for the MD PhDs, but that's not what I mean at all. Physician scientists come from all calibers of the spectrum.
Certainly. And not the least of which is my own advisor from undergrad, Dr. Amanda Muir, a gastroenterologist, MD, who was raking in funds, research funds at UPenn, doing very well. So that's certainly an
It's not
MD.
about the degree, it's about the training,
Yes.
right? And I think that's the key point.
And not just about the training, but being being right where it's uncomfortable to be right at that time and catching a trend early. Uh, and this really brings me to my next question. For a lot of MDs without the formal research training, how are they able to find trends before they catch on and are able to, I guess, choose the bet on the right horse, so to speak, of research?
I wish I knew. I was hoping that maybe you would tell
Oh,
me.
I wish you knew.
But
Okay.
yeah, the yeah, that's a I think that's a very broad question that speaks to scientists in general. I think mentorship is a big part of this. And when identifying those who are visionary, who do good work, and being able to cross-fertilize through interactions with them.
Hmm.
I think, moreover, the we often think about mentorship as being sort of a one-person endeavor, right? You have one mentor. That mentor guides you through your career and through maybe your scientific interests and so forth. But mentorship is actually it should be like there's a book a while ago, It Takes a Village. And I
Yeah.
think that statement also fits for mentorship. You could get different experiences from a collection of individuals, and you take the good and the things that you want to retain from all of them. And I think it's in those ways, through different interactions, different ideas, that one finds new avenues of
Hmm.
investigation, and can get on real tangible unmet needs that can benefit medicine and patients.
Certainly, certainly. And now, moving from the individual deciding research priorities toward a little bit later in your career when you rise to the point where you get to decide what gets funded, what doesn't, the larger research directions of institutions. I was talking to Dr. Ben Seat, who was the former chief medical officer, United Nations, and he leads Singapore's healthcare research. Um, and he was saying that the way Singapore approaches this is that take they look at what the US and the UK are invested in, and they're doing heavy cardiovascular research and cancer research and the things that'll lead to the, very attractive new drug opportunities and exciting new scientific breakthroughs. And he said, Singapore doesn't have, it's like a small city, it's 6 million people. It doesn't have the resources to invest and compete at that level. And so when it's competing against Johnson& Johnson, for instance, you know, way back decades ago, he decided that Singapore will invest 20% of their entire budget toward dermatology research, just randomly, and become the world leader in that niche. And ever since, dermatology's caught on, immunotherapies and all of these new things. Now large companies are starting to awaken to this opportunity, but Singapore's already top three. So when you're thinking of the way that your institution is uniquely positioned within the world, be it Singapore or Harvard or whatever it may be, how do you find what the unique strengths of your institution are to help you bet on the right course?
That's a great question, and I think I wish I had a sort of a very logical and data-driven answer to that. But I'm not sure that I do. I think input from lots of stakeholders is important. You kind of need a crystal ball at some point to know where the biggest advances and the needs are. And there's so many places that are deficiencies in terms of how we care for the ill. So it's challenging, but I think this is sort of the setting directions and thinking about the future and where resources should be invested is really a group effort. You get a lot of smart people in a room, and I think you can sort of get some sense of where to move forward. The MIT Harvard um, marriage is there are many strengths to bring to bear. On the MIT side, I think our strengths are really the engineering and computer science. So there's a clear-cut path, I think, for engagement of MIT in the scientific enterprise. And the
Sure.
HST program has a long and distinguished history of training those that do the quantitative engineering, regenerative medicine, tissue engineering, and more recently in the AI space.
Yeah. And so HST has become legendary then through this marriage for producing physician scientists. What does HST look for that traditional admissions metrics simply can't measure then?
Yeah, that's a good question. I think um, the so applicants to the HST program who are the most successful are those that think about the world in a quantitative way. I think that's one of the things that differentiates HST students from others. And when I say quantitative, I don't necessarily mean that one is doing engineering or applied mathematics. Quantitation appears in all aspects of science. And I think that's one unifying theme. Moreover, I think that for for HST students, the um, science is a lens, or scientific approach is a lens in which they approach patient care. So we try to teach very strong foundations in pathophysiology, underlying principles in the cardiovascular course, for example, that I teach. We model the cardiovascular system as a resistor um, and a capacitor as an RC circuit, and then and you don't have to know anything about circuits at all because there's only a few very simple relationships. And from those, you can sort of reason out what the pathophysiology is in response to different disease states. So we try to, embed fundamental concepts that they commit to memory and those fundamental concepts. Through them, they can understand the pathophysiology and the disease. And not everyone thinks about the world in that way. But I think HST, we specifically look for evidence of that sort of approach to science and the world in our applicants.
Hmm. Hmm. And so, if you could redesign medical education from the ground up today, what would disappear entirely?
Oh my goodness. Wow. I got to be careful what I say because I think this is something that may get me in a lot of trouble. Let me respond very generally. Very
Sure.
generally. I think there have been some good trends in the last few years. So instead of saying what will disappear, I'll sort of say what a good emphasis is. Getting students in front of patients sooner, I think is a trend that I welcome. When I was in medical school, you spent a few years doing in the classroom, and I was an HST MD student as well. And then you see your patient after like 18 months or 2 years and I think the patient-centered education that begins with the patient and ends with the patient will lead to more thoughtful physicians.
Sure.
The board exams, I have to say, talk about things that would go away, are a little challenging for me to parse. Um, we need some metrics to be able to determine whether one has learned the material and but the board exams and the structure it's always been a little bit, I'm not quite sure how that correlates with clinical acumen and clinical care. There are lots of students that I've seen have done wonderful on the board exams, but in terms of their clinical care, it's not a strong correlation there. So I always wonder what the purpose of those exams are and what we should learn from them. So that's one thing. I'm not going to say it should disappear, but I think it's unclear to me the role that it plays in medical. And when I say board exams, I want to be clear. I mean like step one, step two, the things that typically you have to do before you graduate.
So,
The Oh, I'm sorry. Please go ahead.
no, please.
The only last thing I was going to say is about the AI in healthcare
Mhm.
has become I taught a class of medical students once, and the students would put in Google and Gemini or Claude a question, take the answer, and cut and paste it into the question. And I think that so there's a risk there in terms of, about the responsible use of AI, and it not replacing clinical judgment. And, there is, I think, a greater trend for students to outsource uh, answers to important medical questions to this technology without realizing the limitations of it. So I think having a better understanding of how this stuff works and the role that it may play or that it should play in the patient's trajectory I think is important.
So, very specifically, as AI becomes more powerful, how do we prevent physicians in training from outsourcing their judgment? It's so difficult to pin down.
No, I think absolutely. I think the more that physicians understand how these methods work and you get a better sense of what's their sweet spot, what they can be, what they are performant for, what you should expect from them, and what you should not um, um, expect them to do. This is about trust. You will always get an answer when you ask a question to a chatbot, or some GPT-based model. But whether you should trust that answer and how to integrate that answer into your clinical decision making is the so my view is it's not sort of one or it's not a binary thing in terms of you get an answer and you use it. But with that answer, you have to evaluate it within a context of what you know about the patient's pathophysiology into clinical reasoning. So some of this is educational, and what what we strive to do now recently with the last few years in HST is we have a course, and it's actually the first course that HST students take, and it's called AI in Medicine.
Hmm.
And so these students get a month-long introduction to deep learning, in particular, what it means, ways in which it can be useful, limitations of it, and it's a real hands-on course where students actually have to code certain things. You don't need any coding experience before doing this, so it's not challenging tasks, but it's just to get a sense of what does it mean to train a model, when is a model performant, and seeing failure modes for these things. I think things like that are helpful for trying to make healthcare providers integrate this information into their clinical workflow in an informed way.
Yeah. And so what's maybe a prediction about AI in healthcare that you think is almost certainly wrong?
Oh wow. Oh wow. So there is this there, I hear these statements about, be afraid that AI will take over all of the world,
Sure.
right? It's going to replace and that is, I think, in the healthcare space, I think nonsensical. And that AI will replace the physician in many aspects of what they do. And I think all of that stuff is pretty much wrong. I think there will be some fields where AI will do a lot, like in pathologists who read slides, and I think that there will always be a final person that will adjudicate the final diagnosis given a slide. But I think that much of the reading and will be done. The early reading, triaging of these slides will be AI, I think has a big role in that space.
Yeah.
But otherwise, I think that AI will yield tools that the healthcare provider can use to integrate into their clinical decision making in the same way that they use blood tests.
Mhm.
The results of blood tests or other types of tests and integrate that with knowledge of the patient and their disease and their value system to make clinical decisions.
Mhm. And so about kind of trying to have a crystal ball and look into the future, one of the reasons why I'm asking a lot of how you approach these new technologies and how they disrupt medical education is there are a lot of parallels between this and, work in venture capital and trying to predict trends and also being the director of a large institute and trying to predict where research will go so you can position your institute properly so that by the time the ship has sailed, it is in the right area at the right time. And so that's primarily the reason I'm trying to get at where you think all these trends will go, because that's the job of a venture capitalist. That's really the job of anyone. I mean, going into any kind of uh, business partnership or research. So you've spent decades moving between so many different fields, molecular biology, mathematics, engineering, patient care. How do you decide which problems are actually worth solving?
Yeah, so this is yeah, that's a great question. I think the one distinction I would make between what venture capitalists and their predictive task and what in the healthcare space is that large venture capital, my sense is firms have a tremendous amount of money and they can invest small fractions of this in 10 or 50 different things.
Mhm.
Yeah. One of them gets a big hit, the return is, worth it, right? So I think the approach there is when you have lots of resources, you can take risks, right? Because one big payoff is will pay for all of the failures. Healthcare is very different because you don't have the liberty of sort of making these lots of different guesses because these are very high stakes clinical decisions. And for me, it's the patients that I have seen and the clinical experiences that I've had and the patients that have been admitted with things um, that really there's not very much in the way of treatments for. And I think that guides for me the unmet needs. And in speaking with similar colleagues, their experiences in terms of, you get a very tangible sense of where the unmet needs are. And so you start from the unmet need and then you can backtrack I think in terms of and think about what investments or what research directions, I should say, are most likely going to address that unmet need. So there's a different sort of process and considerations at play.
Yeah. And so when you think about betting big on fewer ideas or people and being really being intentional about what you do, there is always the opportunity for something to fail still. And so looking back, I was wondering if you could maybe speak to a scientific failure that ultimately became one of your greatest successes.
Yeah, so that is and I can speak very granularly about this in terms of specific projects, but I would answer in the following way. I think there was another interview that I gave a while back, and one of the things that I said then that I still believe is that failure is not always a bad thing. Yeah, so failure makes you better. And so in most of the research projects that we do, the ones I think that have led to things that are impactful is that you do something and it doesn't work, right? And you learn why it doesn't work, right? Rather than discarding it. Yeah. And then from there, from learning from that failure, you get a deeper understanding of the problem. And oftentimes you find out that you're asking the wrong question, right? And then so by changing the question, then eventually, so science I think is it's not quite a stochastic process, but it's not far from it, right? You have certain idea, and then there's some random walk that you go through, and you go through many different paths, and eventually you find some place that's useful. It's a long process. It's an arduous process in many respects, but it's very, very worthwhile. Can't be afraid of failure. Most things lead to some sort of failure at first, but it takes tenacity. You stay with it and you'll do something that's useful.
Yeah. I appreciate that. And that really falls into the question of how much can you be dedicated to something for, especially with an MD PhD being such a long and challenging path that challenges you in so many different ways. I mean, first with the MD and the rote memorization, then the PhD and the, oh, sorry.
Mhm.
One second. Can I
Please,
pause?
no worries.
Ah, yes. Okay. Sorry about that. Thank you. Thank you.
No worries, no
Um,
worries.
my alarm for the house went off, so
Everything
um,
okay?
yes, yes.
Okay.
So yeah, yeah. Where were we? Um, so I guess if we sat down 10 years from today, what breakthrough do you think you hope we'll be talking about today that still sounds like science fiction?
Hmm. Yeah, so I think and um, that much of what we do in the hospital will be relegated to well, I'm not going to say relegated. I think that many of the questions that we ask and we can only answer in the hospital will happen at home.
Hmm.
And we're more and more moving to care outside of the hospital, getting a better sense of who should be in the hospital and who shouldn't, and using very simple things to get information from patients at home that's on par with what you could have had in the hospital. So if you look at the literature over the last 5 years, ability to use very simple sensors, things that are available on most people's phones or on a smartwatch. And a lot of this information is has quite impactful for care. And so I think that there will be, it sounds a little bit like science fiction, but I think there'll be more monitors, more ways of sensing in the home environment if it's just Wi-Fi, because it turns out, you know, somewhat surprisingly, that there are things that you can measure from a simple Wi-Fi signal in the home.
Sure.
And there are things that, from your the activity that you can measure from just accelerometers and on your smartwatch. You can record electrocardiograms on an Apple Watch, a Fitbit, these different sorts of, or AliveCore has a cardio mobile thing that you can record. So I think that I think, and certainly in your lifetime, it will be less and less. A lot of these sensors will collect information in the background and be able to provide a great deal of information about your overall health.
Yeah. And so I also wanted to ask, what's the biggest unsolved problem in cardiovascular medicine that deserves more attention?
Yeah, so there's so many of them. And right. I think so even in instances where there are diseases where we think we know a lot of the pathophysiology, why some people do well with medical therapy and some people do not.
Hmm.
How do we gauge those who can respond to therapy and those who do not? Huge example in heart failure and atherosclerotic heart disease, peripheral vascular disease. It's just really, really unknown. And so I would say, as a general rubric that goes across many different diseases, personalizing therapy, what therapy should you give to a patient conditioned or predicated on their precise phenotype, what they look like, um, and their medical history, what they do on a day-to-day basis. I think that is really a big part. And it's not only in cardiovascular medicine. I think it's a general problem across many, many, many medical specialties.
Hmm. And that really speaks to the power of personalized medicine as well. I mean, the future of that with artificial intelligence. And, do you think that there there are arguments surfacing that doctors are now the, for instance, the dosing of medications and all of these other things, as personalized medicine comes about and people start to learn more about epigenetics and genetic responses to different drugs, is there still a role for doctors to, or how will that role change or evolve over time?
Mm,
It's just so many data points to take in for
yeah.
exactly what medication will work for what person and what dose.
No, I think that's all true. And I guess I can answer that with a concrete example. I had a patient who I was being treated for something and giving medications based on current guidelines. And during a clinic visit, at the end of the clinic visit, he said, Doc, can I he closed the door because we had opened the door was and he closed and he said to me some things that were not part of his medical record that were really important in terms of deciding what his care was. And stuff that certainly I, recorded in his note, but in not in as much detail as he wanted to, because this was sort of a one-on-one. So I think there are these interactions and data that you gather from one-on-one interactions with patients that can really affect your care for them. That's very hard to quantify in a medical record, very hard to put into a succinct piece of data that you can give to a model and that model can use in its, even if you had Big Brother in the background recording the conversation, right? I'm not quite sure that's something that he would have ever said if he knew that there was Big Brother in the background. It's kind of like a quantum mechanical system, right? You observe it and it changes, right? Just the act of observing it. So I think that there will always be a role for the healthcare provider to integrate these very complex pieces of data that are hard to quantify in a way that you can put as a particular input to an algorithm.
Sure, sure. And So I do want to be respectful of your time, obviously. I know this has been a wonderful conversation, but I wanted to know if there are any words of advice, parting words of advice that you have for our audience of early career scientists and medical students and researchers.
Make sure you love what you do. Make sure you love what you do as much as you can. I've met too many people over the years that are doing things that they don't love, and they've gotten there because of what they thought others think about what they would do, or income considerations drove them to do X, Y, or Z. At the end of the day, the happiest people are the ones that really enjoy what they do,
Mhm.
and one's task in life, in part, is to really find out what you love to do. The more experiences that you have early on in your educational trajectory, the better the chance that you'll be successful in that endeavor.
What a beautiful thing to end on. Follow your dreams, follow your
That's
passions. Yeah. Okay. Well, thank you very much. This has been a wonderful episode of Cutting to the Case. I appreciate you joining. You're an inspiration to a lot of people. So thank you.
Thank you so much, Cameron, for having me. This was
Okay.
wonderful. It was good to meet you.
Yeah, yeah. So this is Cameron Sabet signing off.